the initial and the recording of demographics in the performer, we ask the patients to provide their pre-admission home prescriptions, and we compare it to the post-hospitalization prescriptions. These were both documented in our performer, and there is screen for the number of medications and also whether any of those medications on that prescription were potentially inappropriate for elderly patients. We went a step ahead and further screened the hospital prescriptions on an online interactions checker on drugs.com, and it gives us potential adverse drug reactions for that prescriptions. And again, it also stratifies the potential drug reactions as mild, moderate, and severe. So, study performer included demographics, the comorbidity index scores, their activities of daily living using the GAT score, and screening for various geriatric syndromes that we come across, like delirium, dementia, and falls. We wanted to see if there is any link between polypharmacy and any of these syndromes. So the results of my study, 147, a majority of the patients were young, old patients, that is in the age group of 60 to 69 years, followed by 70 to 79 years old. There was an equal distribution of males and females. 63% of patients had one or more comorbidity, and we objectively assess this using the Charlson's comorbidity index. The admitting unit, majority, 197 patients were actually from medicine and geriatrics, while the rest of the group were taken from cardiology, gastro, and the other specialties. Hypertension was most prevalent comorbid illness, followed by type 2 diabetes mellitus, chronic obstructive airway disease, followed by various other systemic disorders. Most of our patients were independent for activities of daily living, and we gave 1 point for each of these things, like continence, feeding, toileting, dressing, task, and bathing. So the total score is out of 6. So if you see out of 260 patients, a majority of them were independent or required only minimal assistance. Coming to geriatric syndromes, a very small proportion of patients had presented with falls in the last 1 year, an abnormal mini cognitive test, or presented with delirium. So we wanted to correlate polypharmacy with all of these. So you check the home prescriptions. There was no relation to the number of medicines and age, sex, whether they had falls or any of the geriatric syndrome, and it didn't matter whether it was a home or the hospital prescriptions. The p-value was not significant. So we went on to go to the next part of the study, which was assessing the prescriptions to see if there are any potentially inappropriate medications. We used American Geriatric Society criteria. So that criteria basically has 4 tabular components. So these are the 5 tabular components, and this is how it is. Whether drugs should not be used in any situation if you have a safer alternative, or it should not be given with a drug-disease interaction, or should be used with caution because of its various interactions. So using their criteria set down by this society, we went on and assessed our IP prescriptions and home prescriptions. So this is what it looked like. The most common potentially inappropriate home prescription were psychotropics, followed by diuretics, and the next one was 2 or more antihypertensives. All of these potentially had a risk for falls and sedation, dizziness, and geriatric syndromes. So this is what we found in our study. When we compare the home and hospital prescriptions, the mean number of medications was 3 at home, well, it increased to 7, and polypharmacy was almost 30% at home, and it increased to 71% post-admission. The inappropriate medications, however, at home it was 10.4 prescription, and in the hospital it was 7%. The potential for severe adverse drug reactions, as per the online checker, increased as the age advanced, and most of the potential adverse drug reactions were moderate in severity, and the median was around 3 per patient. Polypharmacy increased the total number of potentially inappropriate medications both in the home and hospital prescriptions, but it did not necessarily result in an increased risk of potentially adverse drug reactions. So we concluded that increasing clinician awareness of safe prescribing practices and being aware of polypharmacy will help reduce the prescription of potentially inappropriate medications in the elderly. An online drug checker should be used. They are very cost-effective tool to screen for such events. Thank you.
Dr. Jonita, the geriatric being the vulnerable population, I think it's one of the interesting study. So now it is open for the audience for questions. Sorry to ask, how has it changed your practice? Do you use the online?
We are very, see, we get patients, so when we do screen our prescriptions, not because we get patients, most of our patients are on follow-up from 3 or 4 different doctors, cardiologist, neuro, or a general practitioner back at home. So what they do is they take prescriptions from 3 different doctors and have 3 different prescriptions, and they follow all the 3. So very often there is duplication of prescription, or they just don't know how they're taking it all wrong. So in our practice, we found that it's very common that a patient is taking aspirin from here and aspirin alpropidol from somewhere. Such examples. So this is why we wanted to sort of do this study. And going back, we have sort of, we've always been doing this, but it's before starting even more, that we screen every prescription, every drug. Does have an indication, no indication. If there's no indication, we sort of take it out and try and reduce the number of medications that they are taking. And if there are anything which can cause, predispose the patient to a geriatric syndrome, we sort of, see the safer alternative. If it really needs to be given, or we take it off right away. So in terms of practice, it has really helped us. And having the study also, it sort of increases the awareness that something like this happens. And since the older population have the most number of comorbidities, and they're more likely to get many more drugs than younger patients. So this is of practical importance.
Your medications, did you also include supplements and
Vitamins, if we did, if they were taking vitamins, we sort of documented what was the supplements they were taking and how much was the prescription number. So there is on the online checker, you could actually calculate each of them. So we did include the whole prescription, whether it was inhaled, nebulizations, injections, substitutes, whatever it was, we included it all in the assessment.
I think this kind of an information should get disseminated, and this awareness should be given to everybody in the clinical setting. And also, I feel as a nurse from nursing background, what I feel is that maybe a nurse educator can even give more of her time for geriatric patients' education on this kind of medications and its adverse effects and the safety. Good. Thank you. I now invite Dr. Rakesh S. Ramesh, Associate Professor, Department of Surgical Oncology, to present his paper titled Only Methylene Blue in Sentinel Lymph Node Biopsy for Early Breast Cancer, a Prospective Study.
Good afternoon, everyone. First of all, I thank you, the organizers, for giving me this opportunity to stand in front of you. Also, I would like to thank our main collaborators, Department of Pathology, for patiently helping us in doing this study, as well as our Radiation Oncology Department and Medical Oncology Department. I represent the Department of Surgical Oncology. Study is only methylene blue in sentinel lymph node biopsy for early breast carcinoma. And this is the dye which we are using, which comes as a small ampoule. This is our team. The background of the study is sentinel lymph node biopsy is a standard technique for negative axilla in early breast carcinoma. It helps in staging as well as for planning the actual treatment, and it is also less morbid for the patient. But it is not practiced widely because of the lack of standardization and training, as well as of the fear of incomplete surgery by some surgeons. Sentinel lymph node biopsy can be done using a blue dye technique or a radioisotope technique. And some studies have shown that the combined technique is more accurate than the single technique, either with the blue dye or a radioisotope technique. Unfortunately, most of the oncology centers in India are not having a nuclear medicine department. So radioisotope technique may not be possible at that time. And only dye technique has been studied in many centers and found to be accurate. And of dyes, methylene blue and isosulfan blue are available, and methylene blue is more cheaper and is easily available. The cost is around 30 rupees per 1 ml. This study is an effort to look for the efficacy of methylene blue in sentinel lymph node biopsy for early breast cancer patients in a teaching hospital, and to standardize the technique as well as to have some follow-up data. The study was done in Department of Surgical Oncology between May 2015 and April 2016. 40 patients were studied with early breast carcinoma. Ethical committee clearance and informed consent was taken. 3 ml of 1% methylene blue was injected either perioral area or peritumoral area, and look for the sentinel lymph nodes in the axilla. Once we get the sentinel lymph node, we do an axillary clearance for the completion of the study. So here you can see the methylene blue is injected in the perioral region, followed by incision in the axilla, and here you can see the blue dye. Out of the 40 patients, 24 patients underwent modified radical mastectomy, and 16% breast conservation surgery was done. The most common location of the tumor was at the upper outer quadrant, 26 patients. And 20 patients had a peritumoral injection, and 20 patients had periareolar injection. And the average number of sentinel lymph node harvests was 2 nodes, and the average age of the patient was 47 years. Average tumor size was 3.9 centimeters. And the results of the study, overall accuracy was around 94.7%, and false negativity was 5.2%. Specificity was 100%, sensitivity 89%, and positive predictive value was 100%, and negative predictive value was 93%. And of the 40 patients, more than 50% was ER positive and HER2 negative, and triple negative was around 15%. We were having a very short learning curve with this technique, and the most common area where we found the sentinel lymph node was near the medial pectoral pedicle, more than 90%. The only complication seen in our patient was they were passing blue or light green colored urine for the first 36 hours, and we had a follow-up of 23 months. All the 40 patients are coming for regular follow-ups. 34 patients are on the adjuvant therapy right now. One patient who had triple negative breast carcinoma developed metastatic disease. So, for conclusion, it is a very accurate test technology with very false negativity, less morbid, it is cheap, and a very short learning curve for the surgeon. We propose that only methylene blue technique is an efficient method for sentinel lymph node identification, can be confidently practiced in centers without nuclear medicine facility, without the fear of incomplete surgery. Once we have standardized this technique, all the patients with early breast carcinoma coming to a center, we are offering sentinel lymph node biopsy. So they get admitted on the day of the surgery. Surgery will be done. If it is done in the morning period, they get discharged in the evening. And the follow-up time, they are free, there is no drain. And we feel it is a practice-changing experience for all of us here who is practicing. And now we are regularly doing it in St. John's. Thank you.
Thank you. I was always looking for cost-effective methods, so this is one of those examples.
Hello,
it's open for.
yeah. What is the advantages of using this dye compared to hello? What is?
Can you kindly introduce yourself?
Yeah, myself Nageshwar Reddy. I am working in infectious diseases in St. John's Medical College. Here I would like to know what is the advantages of using methylene blue when compared to other dyes. And did you try it other than methylene blue in other dyes?
So first of all, let me go little back to history.
Yeah.
We all were taught maybe 3 or 4 years back for all breast carcinoma to do axillary lymph node dissection. From axillary lymph node dissection to make up our mind for central lymph node was very hard. And from central lymph node to practice central lymph node was even more difficult. During that time, we would like to see what others were doing practicing outside. So the most common things were blue dye as well as technetium 99. And for us, getting a methylene blue was more cheaper because we have to see the cost factor for our patients. So that is the reason we are using methylene blue. Moreover, we are still continuing this study. Now we are in the process of making a route map so that this can be disseminated to other people in the other areas so that they can practice. Because now what happens is central lymph node, they have a mind block. They just open the axilla, do some digging and take they don't have a map to go how, which are the sectors to see, where to look and take. So we are in the process of that. It's an ongoing study. So still we are using the methylene blue and we are very happy. We are not used anything else. Because that is what is there done in all the tribes.
Right. Okay, thank you.
One more question. What would you attribute the false negative rate to? Would it be the load of nodal metastasis or?
The false negativity probably in our case, probably because of the nodal, more of deposit. Moreover, actually, initially we were in the process of learning. Probably whether the amount of dye we injected at that time was not adequate, I'm not very sure. So we were all in the process of standardizing the technique. So probably that is the reason why we are having a problem. Thanks.
Thank you very much.
We now move on to some presentations from divisions of the Medical College. I first invite Dr. Sucharita S., Professor of Physiology, present a paper titled Role of Muscle and Fat in Type 2 Diabetes Mellitus, Two Sides of the Same Coin.
Good afternoon, everybody. I think it's a wonderful opportunity to share, which all of us have been talking about, some of the ongoing work with the peers in our institute. And I'm here to talk about the work which we do, trying to understand the role of skeletal muscle and fat in particularly chronic disease, type 2 diabetes. And as you can see, the collaborators in this study is not only within department, across hospital, medical college, and the research institute. So keeping with the motto, I think to some extent we've already achieved that. So let's start with a simple concept. I think if all of you look at the picture which is projected, and there is something called as one-dimensional approach, or in nutrition we call it as one-body compartment model. And in the clinical setup as well, you always take into consideration either body weight or body mass index in order to assess what are the risks involved in development of chronic diseases. So if I ask the question in the audience who are present here to pick up who among these four pictures which are projected have the greater risk of developing chronic disease, let's take an example of type 2 diabetes, because today we are in the mode of taking feedback and so forth. But majority, I'm very sure, would have picked up something which is projected. But what if I say that the risk of developing type 2 diabetes is equally high across all of them? Okay. Now let's move on and give the same four individuals with a different dimension, wherein we're now seeing these individuals in a two-compartmental scenarios, where you can see individuals who are varying in their body fat as well as skeletal muscle. So now you have individuals who are on low muscle, low fat versus low muscle or high fat, or you could have high muscle and low fat, or you could have high muscle and high fat. So the same individual now looking at a different viewpoint. And again, let's ask the same question. Who among these individuals have the greater risk of developing type 2 diabetes? And the answer would lie in the fact that a huge cohort of study has been conducted. And any guesses who will be? As it is shown in the HOMA IR here, the individual with high muscle to low fat has the least risk of developing type 2 diabetes versus any other group of individuals who are there. The message I'm trying to give you is that it's important for us to consider not only considering as body weight, but let's also consider the other body compartment models like the muscle and the fat. So let's shifting the gear. I just want to sort of take you through the changes of body fat, muscle, or skeletal muscle changes which occurs across the life cycle. So here is a depiction of a picture. You can see x-axis your age, and on the y-axis there are some of the outcome measures. So you can see that as you grow older, there is a tendency for us to gain more body weight. At the same time, there is a tendency for us to decrease both mass, and now I'm introducing another term called as the strength. Now, skeletal muscle is a very dynamic organ where you have both metabolic as well as mechanical function. So now it's very important for us to consider it not only as a mass, but also consider how well it can perform. Because all of us know, if you are able to perform better, your metabolic functions are kept up well. Now, here I have just put up a marker. Literature indicates that around fourth decade of one's life, the decline in both mass and strength starts. So those who are in the audience who have not yet crossed 40 might be thinking, oh, I'm not there yet, so I'm still time. But those who have crossed might be thinking, what else can I do? And that's the message what we are working towards. What can we do in order to help prevent the loss of? This is a life cycle change which all of us go through. But what is that one can do to prevent? So quickly, what we have been working towards is something called as the thin fat Indian phenotype. And compared to European population or Caucasians, Indian are built thin frame, and if you put on body fat, or generally we have less lean mass or skeletal mass, and if you start putting on body fat, the chances you developing any of the chronic diseases is quite high. So I'm just giving you an overview of the kind of work which we are doing, and specifically targeting one or two findings what we have built over a period of this large cohort. So we do generally work in the field of pre-diabetes, type 2 diabetes, and healthy control. We have been characterizing them in terms of all the questionnaires, physical activity, dietary intake, body composition, and of course those who could visit or have noted, we do have a skeletal muscle lab. We do measure the muscle strength using the gold standard technique. In order to understand what happens within the structure, you need to understand using some cell work, or what we do is skeletal muscle biopsies, which is a needle biopsy, very minimally invasive, and we do work on what are the changes which have been occurring. So I'm not going to take much time, but I want to just show you some of the data. This is the cohort what we have built, and you can see very clearly that the percentage fat across the three, we would have expected that the type 2 diabetes should have got more fat, but we saw that all of them were comparable. Very surprisingly, we found that the muscle mass was maintained in both pre-diabetes and diabetes in comparison to control. But what was very interesting was that the muscle strength was very reduced, as you can see in the lower panel. So the obvious question for us is, it's good for us as Indians that we are able to maintain muscle mass. But the question is it, what's the mechanism, how we are, or is there something which is happening within the muscle? So moving on with the thin fat phenotype, we started trying to understand, is it the fat within the muscle, what we call it as ectopic fat, which is getting accumulated, and that is causing the muscle mass to be maintained. So it is as new as this paper got accepted yesterday in the EJCL. So you could see very clearly here that the pre-diabetes group had higher intramuscular fat compared to the control, and in fact it was much higher than even the Caucasians or Americans. So very interestingly, we are able to show that after an intervention, this fat actually disappears. And to conclude, this was the first time we show the evidence of fat within the muscle, and also we show that apart from looking at fat, it's very important to look at both muscle in terms of mass and strength in a clinical setup. So majority of the funding has come from Welcome to CBT India Alliance as part of my intermediate fellowship, and my entire team who worked tirelessly doing medical camps and in the clinic, and I'm very thankful to them. Thank you.
I think Dr. Sucharita is an example of a true collaboration, and I think the inputs from the study is really giving us insights into what we should customize on our preventive strategies. When we think about diabetes, I think diabetes, we are going to become the capital of diabetes. That is what the literature says. I think these kind of studies will throw light into the prevention. So, questions from the audience, please.
I'm Martina from pediatric nephrology. Very nice work. I understand that you have seen total body fat from DEXA.
Yes.
So is there a way to look at visceral fat or is it just limited to total body fat?
So that's a good question. So usually visceral fat, we could evaluate either through CT or MRI. And now West has moved towards whole body MRI in order to assess the visceral fat. Whole body MRIs, but we haven't reached that stage. But still, the histological measurement of the fat, what we have done, remains one of the techniques to measure visceral fat. So in summary, DEXA will not give you visceral fat, it can only give you whole body fat. If you want visceral fat, either do imaging techniques, like MRI is a better technique, if not, biopsy based techniques.
Right. And for muscle strength, you use a hand grip?
Yes, so if you, because of the lack of time, I didn't go through the ranges. So hand grip strength is for a small group of muscle, which can be used for epidemiological studies to predict your strength. But we use something
like a screening tool.
As a screening tool, and if you don't have good measures or sensitive measure like isokinetic dynamometry, we do have better than hand dynamometer. Our own department, we have developed our own hand dynamometer, which gives a digital recording. But for all the studies, we've used the gold standard isokinetic dynamometer. So this is a true strength report.
Thank you.
One more question.
Anybody else?
No, I think Dr. Suchita, many of us sitting in this room may want to come to your lab and get answers.
Most welcome. Yes.
Thank you.
Thank you.
I now invite Dr. Gayatri, Assistant Professor of Pathology, to present her paper titled Morphologic and Microscopic Characterization of Placentas in Normal Pregnancies in South Indian Cohort.
Good evening, one all present here. I thank the organizers for giving me an opportunity to share my experience on placental pathology, the project which we have been working for the past 6 years. Today I am going to present only a small part of the project. It's titled Morphological and Microscopic Characterization of Placenta in Normal Pregnancies in South Indian Cohort. The collaborators of this project are from Division of Nutrition and Molecular Physiology, Department of OBG and Department of Epidemiology and Biostatistics. This project has received a grant from Department of Biotechnology. So we know that the placenta is a diary of intrauterine life. It is a surrogate for the fetus. It allows us a detailed study of the intrauterine environment. And placental dysfunction has been cited as an underlying cause for many of the complicated pregnancies. So there is a critical need for detailed evaluation of the placental morphology to understand the placental function and its role in causing abnormal pregnancy outcomes. But unfortunately, placental histopathological examination has traditionally been neglected in our country. There are no large-scale systematic studies to develop normative data sets for the placental parameters so that we can do comparative studies for the abnormal pregnancies. So this has also hindered the development of intervention strategies for prevention of pregnancy complications, especially fetal growth restriction and intrauterine fetal death. So we thought there is a need for standardized operating protocols for examining the placenta and reporting the placental pathology. And these protocols should be robust enough to be executable in a public health setting. So a similar approach can then be applied to examining placentas from complicated pregnancies. So the availability of the normative data will help in comparative studies later. So the aim of this project was to develop the standardized protocols and to create a normative data set for placental parameters. We know that there is an ongoing pregnancy cohort, a birth cohort established in our institute from Department of Physiology or Department of Division of Nutrition, and mothers are recruited in the first trimester of pregnancy, less than 12 weeks. They are described in detail about the cohort, informed consent is taken from them, and they are enrolled into the cohort and followed up their delivery. So if these mothers develop any complications, they move out of the cohort, or if they have any other obstetric complications or medical problems before, they are not enrolled into the cohort. So these mothers, when they develop any complications, they enter into the normal. So these are actually normal pregnancies, single-leg pregnancies, and the placenta at the time of delivery is collected and it is dispatched to our department. So if it is off the work timing, it is put into formalin. Otherwise, the fresh placenta is delivered for snap frozen bits to be taken for molecular analysis. So once it reaches our lab, we take molecular sampling and we do a detailed histopathological examination of the placenta. So the placenta collected in this cohort, the period of 4 years was 546. 60 of them were excluded for various reasons, and 486 placentas have undergone proper examination, and 308 were sampled for molecular analysis. So if you see the demographics of our mothers, the birth weight of these babies are little less than what is reported in the Western literature. It's about 2.9 kg average birth weight, and the average gestational age is 38.5 weeks. The small for gestational age fetuses are quite high, 23% in our population. So we have made a detailed gross analysis pro forma taken from the international guidelines for examination of the placenta, and we have a detailed examination of the cord, the membrane, and the placental disc is taken, and digital photograph of all the placentas that we have got in this cohort is captured for data retrieval. So the gross characteristics of the placenta, the average placental weight is around 400 grams, and most of the cord insertions were eccentric insertions. Unlike it is stated in the literature that most normal placentas are round with a centrally inserted cord. So looking at these placentas, we thought that we should do a morphometric analysis that even the normal placental weight does not produce babies of same birth weight. There is a wide variation in the birth weight from the normal placental weight. So what is this that causes a range of birth weight from a single placental weight was what was retrieved. And then we analyzed the shape of the placenta and the cord insertion using digital images that we captured and a software called ImageJ. We took some measurements of the placenta and analyzed the effect of this eccentric shape of the placenta and the deviation of cord insertion on the birth weight and placental efficiency. So the results of the study shows that an eccentric placenta has a reduced surface area and therefore a reduced placental efficiency, and it correlates with lower birth weight in babies who are small for gestational age, but this relationship was not seen in the appropriate for gestational age babies. So this went into a publication in Journal of Developmental Origins of Health and Disease. So the next important structure in the placenta is the umbilical cord, serves as a conduit from the mother to the fetus. There are 3 blood vessels in the umbilical cord to supply the fetus, and we did a morphometric analysis of the umbilical cord and its blood vessels. We measured around 26 parameters, and we found that the umbilical vein is hypoplastic and the cord is hypoplastic in IUGR placenta. So we do a detailed microscopic examination of the placenta, of various components of the placenta, and in addition, we also look at the hypoxic patterns in the placenta. Broadly, the lesions can be classified as maternal vascular malperfusion and fetal vascular malperfusion and inflammatory lesions in the placenta. Though a few cases in the normal cohort also showed lesions of vascular malperfusion and inflammation, they were less than 10% and they were of lower severity. Coming to the hypoxic patterns in the placenta, these are not generally reported in placental report, but we took interest to see how much is the hypoxia and what kind of hypoxia exists in the intrauterine life, which affects the neurodevelopmental outcome of the baby. So these hypoxic patterns were seen in 8.7% of the placentas from a normal pregnancy cohort. So, but the placenta has got a very large reserve capacity, so this even still led to a development of appropriate for gestational age baby. So the conclusions from this study is that we have a good archive of placentas has been established, a normative data set of physical and microscopic parameters is available. This information is utilized in understanding the pathology of placenta in complicated pregnancies. We are eventually interested in comparing these parameters from multiple centers across the country to establish the placental function and fetal growth. And such an endeavor, we think, will generate data for context-specific intervention strategies which are lacking at present for improving the mother and the child. Thank you. These are the publications from our book.
Thank you. Thank you, Dr. Years ago, who were thought of collecting placentas and studying? It's really exciting. You said you ignored the ones where the mother gets out of the cohort if she has actually
Yes.
had some
Gets
kind
out
of
of the
any
cohort.
kind of medical or other
Yeah.
complications. But are they being stored as
They come into
separately
the
and
normal,
yeah.
they come to the pathology department. They don't come for into the cohort, into the normal.
I'm curious to know if you also have mental health data of the mothers and you got it.
No, so it is mostly what you get is for IUGR, their gestation and
I'll still permit 2 more questions.
Sorry. When you say normative data, how exactly do you exclude pregnancies or mother-infant diets from the sample size?
This present mothers are enrolled as a part of the nutritional cohort which is taken. So these are the control, they have intervention study and they have a control study. So these data which I presented is from the control group of the nutrition intervention study.
Yeah, but suppose they have pregnancy-induced hypertension, they're out.
Yeah, they enter the normal group. That is, they are followed up till delivery, but the placentas are not come. They do not come under the cohort placenta. They come for routine histopathological examination if they develop a PIH or if there is an IUGR in the course of pregnancy. They are also sent for examination, but they are not in the normal group. They come as a pathological placentas. So we have received such placentas also, mothers who are enrolled and in the course of pregnancy they develop some complication. So we have a cohort number given for those placentas, but they will be sent to our department for routine history because those placentas mandate the examinations to the department.
No, the question I just asked one more question. The children, I mean, are they kind of being tracked? I mean, are they accessible for any kind of?
No, so that is the problem that we are facing. Actually, the nutrition people they may have, but the placentas which are received otherwise, we don't have a follow-up. We have only the neonatal period follow-up, that's only the 28 days. After that, we have discussed this with Dr. Soman also that the mother's ID and the neonate's ID are not matching. Till they are in the neonatal period, they go with the mother's ID, that is the MRD number. After that, when they go to the pediatric clinic, they are given a different ID, the MRD number. So to track that this baby belongs to that mother becomes very difficult for us. So we have follow-up for the babies only until the 28 days of the NICU period.
What you're asking is the mother's number should be put in
the MRD number of the mother goes only
the baby's record.
Yes, there should be something where we can match. Yeah. So whatever lesions we have seen, fetal thrombotic vasculosis, they have a neurodevelopmental outcome. The effect on the baby is there. But how to track the baby belongs to that mother? That becomes a problem. We have discussed this issue with
Thank you. Thank you.
I just actually like to clarify that the baby has his own number from the time of birth. He does not get he doesn't go through the newborn period on his mother's number. Okay. He gets his number at the time of birth.
He gets his number, but how do we track that this baby belongs to
the mother's number on the baby's card?
It's on his ID chart.
The other thing is, you will always have a contact number of this mother's. I mean, the important what I think Professor Ashok is trying to emphasize is that long-term cross-sectional, we have such valuable data that it becomes imperative that we follow it up for the first 1,000 days and beyond. I think this will be
as soon as possible, because I would take it as a very important outcome of this session that a very simple clinical addition or so in each of the records should probably help to look at a lot of other things.
So there are ways to get the data, but we have to make a phone call. If systems are in place, then it becomes much easier. Otherwise, we have to have a research assistant who's all constantly working on it.
Collaboration.
I think Pratibha has followed up a few children.
Yes, ma'am. That's what the nutritional part of it is getting followed up. They have research assistants who can go, but the placentas which are sent for the pathological examination, the IUGR placentas, those which show lesions that we want to communicate with the clinician, it becomes very difficult from our side to get the follow-up details. Even the neurodevelopment, at least we need a 2 years follow-up. Then it becomes very difficult for us. So I think somewhere we have to tackle this issue, sir.
I think having someone in the team from their department would also help you. And initially, I think it is told as baby of so and so. Later, when the name changes, I think only the name changes.
Name changes, yeah. The MRD number also for some studies we found very difficult.
We would be really keen from unit of hope to appoint one particular person who can actually get this coordination. It's something we discussed with you soon after.
Thank you very much.
Thank you. I now invite Dr. Bhuvana K.V., Sir, Department of Pharmacology, to present a paper titled Prevalence and Determinants of Multimorbidity Among Patients with Strokes in Hospital-Based Indian Stroke Registry, a secondary analysis.
Good afternoon, one and all. At the outset, I would like to thank the organizing committee members and Dr. Dennis Xavier, who is the primary investigator of Inspire Stroke Registry. So we had the internal collaborators from the Division of Informatics and Division of Biostatistics. So the study titled Prevalence and Determinants of Multimorbidity Among Patients with Stroke in a multi-center hospital-based Indian Stroke Registry. So coming to the definition of multimorbidity, which is defined by, according to the NICE guidelines given by the UK, as coexistence of two or more chronic conditions. So these multimorbidity clusters are linked with higher mortality and morbidity. So the developed countries have already has the established frameworks and model of care to deal with multimorbidity in a systematic approach. So with the regular follow-ups, whereas India we have not yet developed. So the objective of the study among patients admitted with stroke in India to estimate the prevalence and determinants of multimorbidity and outcomes. So this was the prospective registry, which was conducted across 65 centers with 6 months follow-up, with a sample size of 10,329 patients, among which multimorbidity data was available among 8,900 patients. And we conducted multivariate logistic regression analysis to determine the multimorbidity. So these were the chronic conditions which we considered, the 5 conditions among CVD and other among endocrine, neurology, and psychological conditions. And this map shows the centers from which patients were recruited. So 65 centers and across 25 states. So with the results, the mean age was 60.4 years, and males comprised of 65%, and the prevalent select morbidities were CVD, which accounts to around 52%, and diabetes mellitus accounting to around 24%. So this is the patient characteristics. So the socio-demographic characteristics and the total patients which was included in the study was 8,900, and the stroke alone was accounting to 40%, that is with no multimorbidity, and multimorbidity, that is stroke with more than or equal to one condition, accounting to 60.2%. So that's the prevalence. So among sex, the female patients were associated with higher multimorbidity by 1.29 times, and age with more than 50 years were associated with higher multimorbidity with 2.16 times, and among the semi-urban and urban locality patients were associated with multimorbidity, and with the socioeconomic status, rich and middle class patients were associated with higher multimorbidity and was significant. So the outcomes at discharge, death was seen with a high prevalence, little high prevalence when compared to no multimorbidity group. though it is not significant. Whereas the ranking scale of score 3 to 5 were associated with higher multimorbidity by 1.15 times, which was significant. And the mean drugs at discharge were prescribed, it was prescribed more among the multimorbidity patients and was significant. And the length of stay was not significant with the patients of multimorbidity. So these are the rates of comorbidities overall and by gender. As you can see, CVD is higher, that is around 52%, and diabetes accounting to 24%, and the rest comorbidities were atrial fibrillation, depression, which account to around 2 to 3%. So in summary, in patients with stroke in India, 2/3 had multimorbidity with higher prevalence among males, and females and of rich and middle class with urban and semi-urban locality were associated with higher with multimorbidity. And at discharge, in those with multimorbidity, the ranking score was higher and the mortality was slightly higher. So as in developed country, we need frameworks and model of care to deal with multimorbidity. Thank you.
Thank you, Puna. Just a sharp contrast with just trying to see, the previous study we are saying we need to build connections across the records of mother and child within the hospital. Yeah, and this is a massive enterprise building connects with patient outcomes across the country. Very striking.
Just one question. It's a good multi-centric study, but then what is the definition of rich? Like, which basis have you taken for your socioeconomic status?
With the Kupuswamy classification.
So does it have rich as one category? Not really sure.
Not
Higher socioeconomic.
Yes.
Just to clarify, it was not focus on classification that we used. We used a more clinical definition, and that was correlated in a different way. So it is not
Thank
focus
you,
on
sir. Thank you. That's what I was wondering, because I'm not seeing that under Kupuswamy scale. So anyway, any questions from the audience?
Just a small methodology question. If you have any problems with the quality of data, looking at it as a registry from multiple sources?
Actually, that's why we included only 8,900 patients where we can get data which we need to analyze for multimorbidity. So the missing values of more than 5% were excluded.
Any other questions?
My name is Tony Raj. Did you find any data on the age of onset of these events? Like, there's an increasing trend of younger people developing such episodes. So did your data showcase any of that?
Though we saw the increasing age had a high number of stroke and multimorbidity, but it was very less. As said, more than 50 had higher benefits.
Thank you, doctor.
I now invite Dr. Jyoti S. Prabhu, Associate Professor, Department of Molecular Medicine, SGRI, to present her work on role of translational research in personalized medicine, lessons from research on breast cancer series from an Indian cohort.
Good evening, everyone, and I would like to thank everyone for this opportunity to present our data for the first time. We have been doing this study for the last 10 years, so given the short duration of time allotted here, I would like to just present a small bit of work.
This is a collaboration between multiple departments, mainly the surgical oncology, medical oncology, and department of pathology. We actually were fortunate enough to get funds mainly from philanthropic donations, that is the Nadatu Trust, which continued to support us for the first 7 years with huge funds, along with which we had multiple other Indian and international agencies through whom we brought more money and collaborated in order to complete this work. We at the Division of Molecular Medicine, that is the Breast Cancer Research Unit, actually started our first study in the St. John's Medical College, but subsequently did move on to other two hospitals, mainly the Rangadurai Memorial Hospital, and which turned out later to be Shankara Cancer Hospital and the Research Center. And this study, we recruited breast cancer patients from the year 2008 to 2013. And all the patients whom we recruited were through an entity which we call as Adhara, which means support for breast cancer. And in total, we managed to actually recruit exactly 446 patients who were with whom we collected all the clinical information possible, a bit of tumor tissue and blood samples at various intervals, and then longitudinally followed them up for the last 9 years. The median follow-up of this cohort as of March 2017 is 72 months. And I would also like to say that a phenomenal achievement has been we have complete follow-up in 97% of these patients. We've just lost about 3% of the patients to follow up, and all the molecular characterization has been done on this entire cohort. So I wouldn't go into the details, but just to put down some of the observations that we have made, as has been reported in multiple studies from India, a higher proportion of patients of breast cancer, even in our cohort, present at a later stages. So we have higher proportion of stage 2 and 3. And one more thing which has been always said about Indian breast cancer is the higher proportion of receptor negative and therefore triple negative breast cancer. We have almost 40% of our patients who are receptor negative, and at least a quarter of them are having an aggressive disease called the triple negative breast cancer. Since we have the follow-up, we are now able to see disease-free survival in this group. And one striking thing that emerges is that stage 1 and 2 patients tend to do well, whereas stage 3 have a poor prognosis, as you can see. And if I divide these breast cancer patients based on the hormone receptor status into 3 different classes as they are recognized and treated today, that is the hormone receptor positive, the HER2 positive, and the triple negative, it is very clearly emerging that the hormone receptor positive have the best prognosis, and the triple negative and the HER2 positive breast cancers tend to have a poor prognosis over a period of time. Now, we all know that the treatment in breast cancer is actually optimized based on the stage of presentation plus their hormone receptor status. But I would just like to showcase 2 cases from our cohort who incidentally were young, presented in early stages, and were treated stage appropriately, but were unfortunate to have events occurring within the first 3 years after diagnosis. So they both had small-sized tumors, were lymph node negative, and underwent surgical treatment followed by hormonal therapy, but had multiple metastases very soon. This indicates the need for more markers other than already known clinical prognostic factors. And one thing that has happened over the past decade in breast cancer research has been the development of multiple tests, so-called molecular tests, which are mainly based on gene expression analysis on the tumors, which have all been actually recognized by multiple regulatory agencies like the US FDA, the NCCN, and all these tests help in substratification of these patients to identify patients who need an aggressive therapy or who can be spared chemotherapy. But most of these tests are not applicable to our patients simply because most of our patients present in late stages, or they are simply unaffordable and no insurance is covering them at this point. So we set out thinking, can we do something about it? So what we have done towards this is, we first actually standardized our methodologies to work on formalin fixed tumor samples for molecular analysis, and developed multiple model-based probability scores which are prognosticating, exactly like how the other tests have been developed, and check them against the validity of this probability scores was checked against survival, since we had follow-up on these patients. And then to each individual tumor, evaluated the probability score and put them back into the cohort and saw where do they stand. Now, if I do the same thing for these two cases that I showed you earlier, one of them, which actually was a very small tumor, which had the ER/PR positive, so tends to have what we call as a high tumor aggression score. So probably she needed an aggressive chemotherapy despite being lympho-negative. And the other one, though she is ER/PR positive, she had no ER downstream signaling, and so probably again needed chemotherapy. So to conclude, what we started out to say that we would understand molecular heterogeneity within breast cancer, that is just understanding the biology alone, if applied in a proper way, probably may help in developing techniques and methods to identify these patients and may have therapeutic implications. The findings have been published in these two papers. I would like to thank all the collaborators here for making us do this possible.
Thank you very much. Foundation grant, excellent clinical biological characterization, great use of support groups, and excellent follow-up. Thank you. Any questions?
Madam, the cases we have shown, just now, the two case scenarios we have put up. This one, tumor size of 1.5 centimeter, grade 3, lymph node negative, ER/PR, no positive, HER2 negative. Patient has undergone BCS, axillary clearance, no chemotherapy. That is the point which I am not understanding why the patient was denied chemotherapy at that point of time. Because anyway, we are not doing any markers or studies here because of, as you have told, the cause factors. But if that patient, if he had received chemotherapy at that time, he may not have gone for metastatic disease at that point, because 1.5 centimeter for a grade 3 disease. I am not sure why it was denied.
I would actually request a medical oncologist to answer that question. And as long as we were told, since I am not an expert, I could only comment on it that a small disease, though I agree it is a grade 3, lymph node negative, but both ER/PR positive and HER2 negative,
No positive.
was actually put on only hormonal therapy and not on chemotherapy. That's exactly the point that she been treated. This event could have been prevented.
So bring facts to learn for clinicians. Yeah. Any other? Thank you. Thank you.
Now invite Dr. Syed Fazil Ahmed from the Infectious Disease Division of SGRI to present his paper on emergence of new genotypes and lineages of dengue viruses during the 2012-15 epidemic in Southern.
Thank you very much for this opportunity. Today I'm going to present the findings on emergence of new genotypes and lineages of dengue virus during 2012, 13, 14, 15 epidemic in southern India. This is the overview of my presentation background, objective, methodology, research of phylogenetic answers, conclusions, and implications of the study. And coming to brief background of dengue virus, it has got 4 serotypes, and 1 and 3 are genetically close, and 2 is divergent from 1 and 3, and 4 is the most divergent of all. And molecular clock answers, the hypothesis says that these 4 virus emerged from single virus due to mutation happened thousands of years ago. And homology between sequence identity between these four serotypes of 68%. And genetic within serotypes, there are several genotypes also present because of mutations due to error nature of the RNA, like rich transcriptase. And gene flow and recognition events occur during co-infections. These are the major things for genetic diversity of genotype, and this leads to evolution of new genotypes and new serotype, and will lead to antigen infections varying pathogenicity based on serotype and genotype. And there's a hypothesis which says how these four viruses would have entered into human cycle from the symbiotic cycle several hundred years back. Ago, it was circulating in wild methods, and it was transmitted between the methods by the Aedes species of Africa, and it is entered into rural areas where humans are living. And from when the humans entered into city life, there is human cycle. It is entered into the mosquito species of the human cycle, and that's how these four viruses would have evolved emerged from the symbiotic cycle to the human cycle. And rational and objective of the study is to, since high genetic diversity is demonstrated among 25 serotypes, there's no proper reports on what kind of genotype is circulating in southern India. There are very few reports. So hence, based on this rationale, we framed an objective to describe the molecular evolution and epidemiology of circulating strains in outbreaks of different time points, October 2012 to November 2013, and October 14 to November 15. There's a gap. There's a gap period. And in the same geographical area of southern India, based on the absolute purification sequence using molecular phylogenetic methods. And this is the methodology, and this is a patient group. This is some pediatric patients, 6 months to 15 years with febrile illness, suspected of acute dengue infection based on the diagnostic criteria of WHO 2012 dengue disease, admitted to St. John's Medical College Hospital, and patients are from 3 southern states. Like these are the 3 southern states like Karnataka, Andhra, and Tamil Nadu. And this is a methodology for the sequence and phylogenetic analysis. We amplify capsid region as it is mostly used for genotype analysis. We amplify the region, partial capsid membrane region, and we did the sequence alignment using cluster W. And using the aligned sequences, we constructed phylogenetic tree by using reference sequences from GenBank. And coming to results, and if you see in 12, 13, 13, 14, 15, the pattern was entirely different. In 12, 13, dengue 2 and 3 were predominant, accounting for around 38% of total, percentage of proportion of serotype. And whereas in 14, 15, dengue 1 was the predominant, followed by 2, 3, 4, and both outbreaks we also detected co-infections with multiple serotypes. Whereas in 14, 15, dengue 1, either with the 2 or 3 is the most predominantly co-infecting serotype. And coming to phylogenetic analysis, we followed a criteria for selection of samples. It is based on the random sampling stratified by serotype, and approximately 15% of the PCR confirmed were selected for sequence analysis. And since we retained 30% of the representative of each serotype, we included around 30% of 1, 2, 3, and remaining 6% was the dengue 4, since it is the least related serotype. And this is the overall phylogenetic analysis, which shows that how dengue, these 4 serotypes are highly, divergent with various geographical areas. And with the phylogenetic analysis of dengue 1, there are 5 genotypes reported so far. And in 12, 13, dengue 1 genotype 3 was the predominantly infecting serotype in 12-13 outbreak. We detected in 6 out of 7 samples. And whereas like in 14-15, genotype 3 was the least predominant, least detected, only 5 out of 26. And coming to genotype 1, we identified only one genotype 1, one genotype 1 during 12-13 outbreak. There is highlighted actually in red arrow. And whereas like 21 genotype 1 predominated in 14-15, and this new genotype was replaced like already existing genotype. And this is the map depicting how this genotype 1, 21 genotype would have entered into India. And this is the basically this genotype 1 was introduced from Thailand to China in 2001, and it is spread from genotype spread from China to Singapore in 2005-6, and it is transmitted from Singapore to yeah. And this is dengue 2. We found a new lineage of dengue 2 strains evolved. And these are the dengue 3 phylogeny. Only 4 isolates were related to lineage 3 strains, and most of the strains were related to Singapore and China. And 2 strains were clustered separately from the lineage 3 strains. And these are the dengue 4 phylogeny. I mean, these dengue 4 strains further diverge into 2 different clades. Conclusions from the study. This is the first report from different epidemics that reveal the rapidly changing epidemics of dengue circulate in southern India. Introduction, emergence and predominance of G1 strains replacing G3. Emergence of new lineages of dengue 2 strains replacing already circulating endemic dengue 2 strains. Circulation of strains related to the lineage 3 of dengue 3 and presence of 2 clades of dengue 4 genotype. And implications changing epidemics of infection.
Maybe we come with those questions. I mean, an example of hard work that has to go before we quickly talk about the strains that are there in a given patient or what it might respond to. Thank you.
Question. If the team analyze the clinical severity or the differences of the clinical manifestation outcome of these situations, what did you find?
Any statistically significant difference between the infecting serotype and the disease severity.
So
even though dengue 2 was found to be, the proportion was little higher than compared to other serotypes, but overall there was no statistically significant difference between the infecting serotype and disease severity.
And any explanation why it has changed serotype over the different period of time?
In our study, because of the replacement of a new genotype entered into southern India, that has replaced the already circulating.
Just one more question. Does it affect all the age groups equally? I'm just curious. Who are the people who are dying of things?
No, pediatric patients are the most affected. Children are the most affected compared to adults. Maybe because of various factors they
Was there any association to which serotype was?
that is like really
The index you would have used for classifying the serotypes, I mean, is there any hopes of that informing pharmacological possibilities? The kind of what the actual method you have used to identify the serotypes, I mean, does it connect with any kind of biochemical pathways or something that can indicate some pharmacological options?
I now call upon Dr. Abhijit Bagmare, Division of Medical Informatics, SGRI, to present a paper titled Electronic Health Records and Information Portability, a pilot study in a rural healthcare center in India.
Good morning. I think that's what happens when you're trying to find medical records of your near and dear ones, and you don't get them. It could be your dad, mom, so on. So that was one of the problems we tried to solve with one of our collaborators, community health, community medicine department. So this is the study titled Electronic Health Records and Information Portability, a pilot study. So this study has been already published, and there are obviously authors. Department is medical informatics division. Then collaborators are community medicine department, and then this study has been funded by G Healthcare. So the aim of this experiment was to evaluate feasibility of implementing an EHR system which could port data using either USB card or an SMS-based services. So this pilot study was implemented in one single site, that is Community Health Training Center, Moglur, which has geriatric and MCH clinics. So these two cohorts were included in the study. And then this was carried over April to December 2011. And deployment was done through the clinical mapping, interviews with clinicians, other healthcare workers, and key informants like sarpanch of the head of the village and other known people or other well-known people in the community to know what are different needs could be there and to get a buy-in so that people could use our solution, obviously because it is used by the patients. And then the software solution was developed and deployed at the site. So this informatics study has three different components, or rather any informatics study will have these components. There will be tools, people involved, and then processes. Tools will help collect and analyze and disseminate information. So computer was used, personal computers was used to collect data. Then USB card and SMS, they are used for data portability, and SMS also used for taking consent from patient as a participation and the registration in the study. People were involved, clinicians, data entry operators, and patients. Then processes were registration, encounter data capture, and retrieval of the information. So this is a high-level overview of how this Ayodhya portable record works. So at a Moglur center, there was a server which was deployed, and data was captured on a personal computer and transferred to the server. So first patient was registered in EHR, a confirmation SMS was sent. Then patient data was transferred into EHR. When patient has encounter, at that time data was ported to the card, and then card could be used on any computer, and then it will open up a auto-run program, and patient has a PIN number which patient can give to doctor, and then they could read this data. Whenever they come back to our center, that time data could be again read and at the follow-up visit. So there was another solution which was given for all the participants. They were given SMS-based access to their healthcare records, like last lab tests which are done, what are the medications patient is currently having, what are the health issues which are there. So they could dial particular numbers by sending a code, and they could get the information based on the code. So what data was collected? So for both the cohorts, demography, problem list, past history, history of present illness, family, social history, physical examination, lab investigations, and medication data was collected. For geriatric cohort, additional things which are collected were functional status, mental status examination. For maternal cohort, obviously the obstetric history, obstetric examination, risk factors, anthropometry, and immunization status and schedule was captured. So these are sort of results. So for geriatric cohort had 233 participants, maternal clinic had 75 participants, and one group of each of these cohorts, they were given USB-based card and SMS both, and then other group was given only SMS-based access. And total 10 participants out of this entire 608 participants, they accessed SMS-based service. So we achieved 100% card compliance, that is patient getting card to their visit by third clinical visit. SMS usage, there were 83 SMS requests which were raised by 10 different users. They were mainly asking for demographic details, 61%, health issues, 34%, and medications were just 5% actually. And all these 83 requests were honored, and this was cross-verified by the system norms. So, what is the conclusion? The dual portability model implemented here demonstrates utility of this concept, and now to think of it like after 8 years, these kind of things are coming into streamline or mainline of the health informatics or medical care, and this system could be deployed across different systems easily, provided you have a combination of people, processes, and technology. Thank you.
Thank you. That was a great initiative. Like we said, information is at the fingertips today. So, utilization of technology, we can know how we can use it in each of our settings, in our hospitals. We have told from this that even to the rural setting, it is really possible. I think that's a good initiative. Any question from the audience? Thank you, Abhijit. That was fantastic presentation. I see that data was collected, patient health data was collected in Bangalore. If the patient shifted from Bangalore PSC to another, like a private provider, would the data be still available? Was the private provider be able to see all the reports that was generated?
So, patients who were given the cards, they could plug in their card into any computer which could access USB card, and it could open up a browser, like a Chrome browser or something. There, all these records could be viewed if patient provides PIN number.
Okay. Have you actually checked that aspect of the patient moving to a private provider, and if the private provider did actually access his health reports?
No, we didn't.
Not. Any other question?
Since cost is a major feasibility factor in a large-scale intervention, approximately, if you really want to apply it here in a large hospital like us, it's a very good idea. What would be the cost for using something like this?
So when we got these cards, they were really costly, but they used to hold very less information. And now these USB cards, as such, they have become really very cheap. Like if you want 1 GB pen drive, you may not get it actually. Minimum you could get is 4 GB pen drive, and it's just like maybe 200 rupees. If you buy it for bulk, it will be much lesser. And then printing a card is not much actually. But then there are other things which are required for implementing this kind of system or health information system in hospital. So actually it's feasible, and the costs they are much less compared to the benefits.
No, I didn't understand how is it different from a general USB when you're saying it's similar to a USB.
Yeah, it's a USB card.
Yes.
So when we implemented in 2011, it was not easy to get in shape of a card, but now you can easily get those cards. So cost is not an issue if you want to deploy this cards to patients.
Can you also make sure they don't have songs and stuff on the SIM card later?
We can lock it.
Thank you.
We move on to the final presentation of the day. I invite Mrs. Shiny Matthew, Professor, Childhood College of Nursing, for her paper on comparison of abdominal girth and gastric residue volumes in assessment of feed tolerance in preterm neonates, a randomized controlled trial.
Good evening to all of you gathered here. I'd like to thank the organizers and my team members for supporting and for cooperating with us throughout this time. This was a study which is done to say between St. John's College of Nursing with St. John's Medical College Hospital, and this was published in the Advances in Neonatal Care 2018 August. The investigators, Sherry Thomas, was an MSc PG student. She was the PI. Dr. Saudamini, myself, Shrija Bibi, Reena, and Renjita was the staffs of an ICU, and Dr. Sumandra. So the background of the study is that, as we all know, that nutrition is something which is very crucial to the survival and to the neurodevelopment of the preterm babies. And gavage feeding is very common in neonatal intensive care unit, especially for the premature neonates. Evaluation of gastric residuals consists of measuring the volume of milk remaining in the stomach at a variable time after a feeding. Depending upon the prescribed feeding schedule, these neonates can undergo gastric residual evaluation more than 10 times per day. And the preterm babies, they already have a poor gut motility, they have a decreased acid production, and also the poor esophageal sphincter control. Thereby, it results in a higher gastric residual volume. And thereby, we cannot consistently say that checking the pre-feed aspiration can be a standard for checking the pre-feed, the feed tolerance in the preterm. The recent facility-based newborn care guidelines suggest the use of abdominal girth monitoring to look for feed tolerance. Though it is the common practice in every NICU is that we check the pre-feed aspiration. So thereby, we wanted to check these two simple interventions to see that which one reaches the baby to the full feed. The problem statement, the randomized control trial to compare feed tolerance among preterm neonates with pre-feed aspiration versus the abdominal girth measurement technique in a selected hospital, Bangalore. The objective of the study to compare pre-feed aspiration for gastric residual volume and pre-feed measurement of abdominal girth in the time to reach full feed in preterm babies. The hypothesis that there is a significant difference in the feed tolerance between abdominal girth measurement group and pre-feed aspiration group at 0.05 level. The approach used was a quantitative approach. Design was an RCT, setting was an ICU of St. John's, and the sample was 50 preterm babies admitted in an ICU receiving gavage feeding, and which met the inclusion criteria. The sample size was 50, 24 in the control group, and 26 in the study group. The sampling procedure was randomly enrolled into a study and control group. The inclusion criteria: neonates born between 26 to 37 weeks of gestation, neonates having birth weight 750 gram to 2000 gram, neonates likely to receive gavage feed at least for 48 hours. The exclusion criteria: neonates who have a major GI anomalies. Instruments used was a proforma to collect the baseline variables, protocol for feeding procedure, as well as to check the AG measurement and a feeding chart. So these were the protocol which we developed to make them understand the staff how to check the abdominal girth and monitor aspiration, the pre-feed aspiration, and how to document. And also, this was the feeding chart used by the staffs in the MSc. The method of data collection, permission was obtained, and the directions was given to the entire team how to go about the study, and the parents was informed that the consent was taken. A class for the staffs regarding the protocol for abdominal girth and pre-feed aspiration was taken before commencement of the study. Samples were selected based on the criteria and assigned to control and study group. The intervention was continued until they reached the full feed, that is 150 ml per kg per day. The results and the discussion, we did the comparison, and we found that in the study group, the median, the AG group, the abdominal girth group, it was 6 days to reach the full feed, Whereas with the control group, that is the aspiration group, it was the median base was 9.5 and it was significant with the p-value 0.04. So to conclude the study has shown that monitoring of abdominal curve as a measure of heat tolerance enabled the preterm babies to reach the birth earlier. It also reduces their hospital stay and helped them in the early discharge. And we also, soon after the study, we started practicing it in our NICU setting.
Shiny is a good study. Today we look at better outcomes and quality nursing care, and feeding is one of the pure nursing intervention. And it started as a PG dissertation, and it was nice that it continued in the department and the faculty took up. And because I'm also aware of this study, that's why I'm just adding few points on it. I think it's one of the best studies that our College of Nursing has done. Any questions on this? No questions?
Thank you. In that, we conclude the presentations, and I thank the chairpersons and I request them to distribute certificates to the presenters. I call upon Dr. Ashok to first come, and I call upon the first three presenters, Dr. Nivedita Kamath, Dr. Jonita Fernandez, and Dr. Rakesh to kindly receive their certificates. I now call upon Dr. Bindu to distribute certificates to the next three participants, Dr. Sucharita, Dr. Gayatri, and Dr. Bhuvana. I now request Dr. Tony Raj, Dean of SGRI, to distribute certificates to the next four participants. I call upon Dr. Jyoti, Dr. Syed Fazil Ahmed, Dr. Abhijit, and Mr. Shiny Matthew. Thank you. With that, I hand over the mic to Dr. Tony for
I appreciate everyone who joined this oral session here. Thank you, chairpersons, for handling this session so well. Firstly, I was very touched and encouraged to see the participation today. This was wonderful. It's been so enlightening and encouraging to see that the entire academy was out here. It's opened up many positives today, and right from the messages that you heard from across the various exhibitors, from our director to keynote speakers to YPs, I think the message is positive. In fact, one of the items was use the obstacles at the path forward. I take this opportunity to thank the team that actually conceptualized this and helped me put this. Dr. Anu Vasudevan, organizing chairperson for this. Thank you. all the schedules and everything. We managed to tie everyone in and put them together. We had a fantastic organizing committee. I'm really pleased to let you know that this team comprised of faculty from across the academy, from the nursing college, from the medical college, from the hospital, from the allied health. They were research institutes, representatives across, and they did a fantastic job. So thank you all for coming together. This is really setting the tone for the next year, so we should really plan and work together as an academy to see how we can really improve this. We will accept feedback. There's a lot of feedback codes you see around. Just use your camera, flash that, and enter your codes. Just send us an email. We'll be happy to incorporate that feedback and improve it, foster more research. We will circulate for those who unfortunately couldn't make it today. We have recorded sessions of some of these events in this morning. We're putting it on our YouTube channel and we share it by email. So I conclude this session. I'm very encouraged. There are still posters in the neighboring room. For those of you who missed it, please walk across. Like those of you who missed lab visits today, our labs are always open. You can always contact. You'll see, you have the map now. You know where these labs are, and you can reach out to us and we'll be happy to link you with the investigators to explain further. Thank you very much. Let's tea served outside, and we will conclude here, hoping to meet all of you next year with more participation. Thank all the supporting staff as well. They've been working very hard across. So thank you, everyone who supported us.
Can we have the organizing committee here? We've got photographs, so I request the organizing committee of the research table kindly take the stage.
Good. All the hard work. I think what we call you for